we're very reactive in long-term care. If there's a fire, we put it out. But we need to really shift to this proactive, preventative practices, and infection control is exactly what we need to do that. It's not just infection control, it's infection prevention and control. So we need to do a lot better at preventing the infections, and that's where the full-time IP comes in.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Dr. Buffy Lloyd-Krejci, CEO at IPC Well. And I've known Buffy for quite some time. She travels all around the U.S. She goes to long-term care facilities and does assessments, trainings, educates, and has really just an excellent sense of humor and empathy. But you'll also hear during today's interview just her passion. And despite it being quite a difficult year, especially in her position and the environment with which she is supporting and the opportunity for improvement that was laid out in front of her. You're going to hear the fact that she is undeterred and her passion is unfazed, if not completely invigorated, by having some attention on the opportunities that lie in front of us in long-term care settings when it relates to infection prevention. And Larry, as I said, I've known Buffy for a while. She's got a great message, and she's always putting in the extra effort and the extra time and energy to improve the industry. And so I think it's just going to be great for everybody to hear her perspectives, especially with everything that we've been living through recently.
Yeah, she's a industry champion, and I'm very interested to hear her passion and to feed off of it and to learn from her. And if there's anything we've heard repeated through the months, in addition to pandemic and COVID-19, it's about infections and deaths in nursing homes and long-term care facilities. So if you didn't think that infection control and prevention in long-term care facilities was important, if you didn't think that last year, you certainly will agree now that it is of paramount importance as we move forward to assure the safety of those residents.
Yeah. Well, let's just get right into it. We're going to be back after a short break with Dr. Buffy Lloyd-Krejci, CEO at IPC Well. I'm Justin Poulin.
And I'm Dr. Lawrence Muscarella.
From 17 Studios, let's get into it. This is Transmission Control.
Joining us now is Dr. Buffy Lloyd-Krejci, CEO at IPC Well. And Buffy, you've joined me on our sister podcast, Beyond Clean. It's been about a year. And since then, you became a doctor. So I'm interested in hearing about that and also having you introduce yourself to the Transmission Control audience. But I'm really grateful that you're going to come on the show today and share your insights around the infection control challenges that have really presented themselves at the forefront over the last 18 months in the long-term care setting. So thanks for coming on.
Thanks, Justin, for having me. Glad to be here.
So why don't you give us a little bit of a background and even give me an update on achieving your doctorate? Congratulations.
Thanks. Yeah, I was actually in quarantine last April when I got the call from my professor that I was officially completed my doctorate in public health and epidemiology. There was no celebration. There was no opportunity to get my certificate. But yeah, I was in a quarantine, so it was definitely the way times were last year, but definitely a passion of mine and wanted to be able to get all the expertise that I can, and achieving the doctorate was definitely a way to do that.
Yeah, that's awesome. And it was not so timely in the fact that you couldn't celebrate with people, but I think it was very timely considering infection control was front and center at the exact time that you completed your degree. And what has that last year been like? Because I feel like probably you got that degree and then you were already working in the space, you were already consulting, but I feel like your work probably took off, like a rocket.
Yeah, definitely. I mean, with COVID as a global pandemic, this new virus, all of our lives have been forever changed. And like you mentioned, I was working in long-term care before the pandemic, really trying to help with awareness for the nursing homes to help them understand the risks that were involved with the high number of infections, serious infections in this healthcare setting, and the high number of deaths. The estimates are still over 1,000 residents that die every day from infections within healthcare settings. Or within nursing homes. This was even before COVID. And so I saw the huge need. And then, of course, the pandemic has brought it to light. And I'm just super excited that we're talking about it. And I hope we continue talking about it so that when the pandemic, as we continue to move in the future, it's not done and over with, but we continue to work on the solutions.
This is a topic that you've been trying to get a lot of attention on, as you were just alluding to there, as you were talking about your last year and sort of the challenges that already existed that maybe weren't front and center, have now had a light shined on them. And I know you told me when I reached out to see if you'd come on this show that you had actually started a book project to increase awareness for that very reason. But when we talk about increasing awareness, what is the audience that you're trying to target with this book project?
Yeah, the audience is really multifaceted. It is the consumer, so those residents that are needing care, as well as potentially their advocate or family representative. It's also to healthcare workers, and it's to policymakers, decision makers. I've been in over 150 nursing homes in the past year, helping them fight COVID. And it was late November of last year that a colleague of mine recommended that I start to document and put this information into a book that can really help shine the light even further on the challenges that have occurred in nursing homes and where we go from here for the solutions. And so it's really for the healthcare worker as well as the consumer. It's really a book for all.
I was going to say, it's really like the public at large. What are some of the core themes that you want to make sure get covered in this book? Like, what are some high-level takeaways that you're really trying to address?
Well, I want people to understand that infection control was a problem in these nursing homes prior to COVID. And so the beginning of the book, the first few chapters actually describe where the industry was prior to the pandemic, the research that was going on, the public health outreach that was occurring, and really how behind the times this industry was and how much work needed to happen. And then it really goes into the pandemic and what I've experienced, as well as other people, other colleagues, researchers, staff, that what they've experienced during the pandemic. And then it goes into the solution. So where we go from here, how do we improve this healthcare setting? How do we improve infection control practices to make this healthcare setting safer, not only for the residents, but also for the healthcare workers, and just making it a safer healthcare setting?
So, Buffy, I had a few questions, and thank you for joining us today. The first one is maybe for myself and for the audience, that you could clarify the difference between what we call the long-term care facility and what we also are talking about today as nursing homes. How do they relate to one another? Is one a subset of the other, the one an umbrella over which the other falls? How do we distinguish one from the other?
That's a great question, Larry, and that's often a question I get. It can be very confusing. Long-term care facilities, you would imagine as the umbrella, and then underneath that are the different types of care that's provided. So you have skilled nursing facilities, or SNFs, which also can be considered rehabilitation centers. You've got the nursing homes or long-term care, where maybe somebody just needs help with daily activities, and they're probably going to live out their life in that setting. You've got assisted living, where they don't need quite as much care. And so those are some of the subcategories, you could say. Many of these long-term care facilities will house all of the different categories within one building. And so we like to say long-term care facilities as just kind of the umbrella, knowing that within a building, you may have a whole different array of services that are being provided. You may have somebody who's rehabbing from a hip surgery in the same building that somebody's living out the rest of their life in that type of environment.
So thank you for that. And that response kind of got my brain going and raised a number of questions for me. But I want to just clarify that when we're talking about residents and patients, are these really the same under this umbrella of long-term care facilities? And can we talk about today infection control in the context of all of this? Or is your specialty focusing on just the nursing homes, or we'll talk about infection control of all long-term care facilities for both residents and what we may call patients too?
Yeah, so typically within the long-term care, you'll hear the term residents versus patients. And this really comes from the history of these facilities, where the person that would come into a nursing home would live there. And so they were a resident of this environment, like being a resident of a community. And that's kind of stuck. Even for like your rehab, we still like to call them residents, because it's more of a home-like environment and not that acute setting that we have in the hospital. In the hospitals, we refer to them as patients, and it's very short term. Whereas in the rehabs or these nursing homes, it's a lot longer term situation. And so we want to have it more inclusive of a community, and this is their home. And so that's why we use residents.
Very good. And we'll talk today about the infection control measures, both for residents and patients. And you touched on something a little earlier about, for example, lessons we've learned with COVID-19 and what we have been taught, and moving forward, what we now can adopt and implement as corrective actions based on what we've learned. And it seems that in the past, we kind of had an awareness that a pandemic could happen. And maybe it was for financial constraints that we couldn't do much about it. But when we look back and understand that airborne transmission of viruses are conceivable, have happened, and will happen again, what has the financial structure allowed that long-term care facilities can adopt that can prevent resident to resident or resident to patient or resident to staff transmission of a deadly airborne virus like the COVID-19? Do we now have maybe negative pressure rooms available to us? Do we have wings within the facility that we kind of can divide off where we can quarantine our cohort patients? What is it that, I don't want to put the cart before the horse yet, but what is it that we have learned from COVID that you think needs now to be adopted and maybe is a long time coming?
Well, this is an excellent question, and we could just talk for hours just about this. And what I'll say, and this is why it's so important to talk about what happened before COVID, because there were new federal regulations requiring nursing homes to have infection control programs. This came about in 2017. And then in 2018, we also had antibiotic stewardship. And in November of 2019, every nursing home in this country that was certified by CMS, the Centers for Medicare and Medicaid, was required to have at least a part-time infection preventionist on staff. So we were inching forward towards this work. We were slowly starting to implement infection control practices and protocols and policies.
I don't mean to interrupt, but I wanted to clarify something because you just caught my attention, and please continue. You said to have a part-time infection control practitioner on staff. Did I hear that correctly? Did you mean full-time, or did you say part-time?
Oh, no, Larry, it's only part-time.
And as a result of COVID-19, are we moving toward full-time? Can we prevent C. diff transmissions, superbug infections, and respiratory transmissions if we don't have a full-time staff member addressing it?
Right. Well, this is one of the big fights, and this is one of the things that I'm very much strong advocate for. I was having a conversation with a policy decision maker earlier. So before COVID, the industry was moving towards this part-time infection preventionist. There was even pushback from some of the advocacy groups for nursing homes to change that to sufficient time, not even part-time. And so you can see there wasn't even this big buy-in for this type of practitioner. And even now, this is kind of a hot topic. Do we need full-time? Do we need part-time? I was talking with Dr. Michael Wasserman. He's a big advocate in California who has stated now that California has made it a law that they have to have full-time infection preventionists in these nursing homes. And it's the only state in this country that has required that as a law. And so we're definitely heading in that direction. And if I could preach from the hilltop for anything, it would be this, that we need these infection preventionists full time and not just on paper, because the problem is they can even be said, I'm part time. This is what I do. But guess what? If you're short staffed, that infection preventionist is working the floor. They're working the cart. They may not necessarily even be devoted fully to infection prevention.
I was just going to say, because I've worked as a nurse, both as a CNA and as a registered nurse in multiple different long-term care settings. So skilled nursing, long-term care, et cetera. And I remember that the way that they addressed this was really through the nursing staff. But you typically, depending on the size of the facility, may only have one nurse on a shift or two, maybe three, depending again on the size of the facility. And they kind of rolled this up into that charge nurse role. But I think what you're talking about is creating continuity with the plan. And so the way that the nursing part works is it's shift work, right? And you're still going to have to, oversee medication administration, any other, types of dressing changes, making sure that the individual nursing plans for the residents or the patients, depending on the setting, are being executed. But then also to have that more long-term perspective is what you're talking about with the infection preventionist or infection control individual that's full-time or part-time, depending on the state and the setting, that they would have that continuity on a bigger picture plan. It wouldn't necessarily be so resident specific with the care that's being delivered. It's about the entire facility. Am I understanding that correct? Why they should be carved out and not have shared responsibilities and really be focused on this one strategy or plan for the facility?
Well, you're right in the sense that we cannot do our job effectively. An infection preventionist cannot do their job the right way, I should say, if they're constantly pulled to the floor. They cannot have patient or resident care load. They cannot. It's just not possible. You're talking about conducting surveillance and reporting and auditing and teaching and educating. And if you've got a caseload of residents, then you're not able to do that effectively. And we really need to shift the way we look at this from this reactive, and I've been saying this for years, we're very reactive in long-term care. If there's a fire, we put it out. But we need to really shift to this proactive, preventative practices, and infection control is exactly what we need to do that. It's not just infection control, it's infection prevention and control. So we need to do a lot better at preventing the infections, and that's where the full-time IP comes in. They're instrumental in preventing infections from occurring in the first place.
So what about we talk about dovetailing the staff responsibilities with the design and the layout of the facility, for example? As a result of what we have learned from COVID-19, are there any design changes that ideally in a federal level are going to be mandated so that we can, to your point, not just control infections, but we can proactively and preemptively prevent them?
Well, thanks, Larry, for taking us back there. And that's important to talk about is infrastructure, because one of the biggest challenges in even combating this virus has been the actual building and what we have in place for infection prevention and control. Look, every single building I go into that's new to me, I'm typically still trying to get them alcohol-based hand rub. I'm just trying to even get them to do the basics of washing hands. I cannot even tell you. I was just in a building last week and I still cannot get staff to do hand hygiene. And so we've got to even start with those basics. We have to get good housekeeping products and chemicals in place. As far as the negative air pressure, this healthcare setting traditionally has never provided care for any residents that require a negative air type of transmission-based precautions. They are cared for in the hospitals. And so we don't have that. What we've gotten better at, as you had indicated earlier, is if there's an outbreak of COVID specifically, then we have gotten better at standing up these individual units, cohorting. It's a massive undertaking, and it's definitely subpar. I mean, it is just what it is, but we do not have the sophisticated equipment. We do not have the sophisticated infrastructure to accommodate this. It is not there. And from my understanding, I do not even hear talks of it changing to that.
Which is remarkable because can you remind the audience, what was the percentage of patients/residents in long-term care facilities who died of COVID compared to the total number of U.S. deaths? Is it something like as high? Could it be as 1 in 4? Is it 10%? Do you know what that number is? Because it's going to be a significant number, and it's going to raise the question that if of the people and the patients and the residents in the U.S. that died of COVID, if the greatest percentage of them came from nursing homes, then I would think there would be immediate changes that would be implemented and adopted as of yesterday. Can you comment a little bit on that, if you know what the numbers are of the Americans that died of COVID?
I know at some point it was 45%, and I honestly haven't tracked it from there. I've seen it even as high as now around 30%. So
I think I saw somewhere around 1 in 4, but it just seems to me remarkable that if 1 in 4 is dying, we really didn't do anything beforehand, and we may not be doing anything afterwards. And so it goes to the issue of a lot of lip service, maybe.
Well, Larry, that's why I'm happy to talk, and that's why I'm writing this book, because in my book, what I'm super excited about is not just about what I've experienced, and this is what it's taken a life of its own. I'm interviewing researchers, I'm interviewing administrators, directors of nurses, infection preventionists, housekeepers, CNAs, advocacy groups. Like it is a book that is written that is the voice of the people in this industry. It's even has residents, their experienced patient family members. So it's like we cannot waste this opportunity. It was a problem before. This pandemic has highlighted the problem that it has been and will continue to be until we make drastic changes in this.
Well, so let me ask you about this whole piece around education, because that's really what you're saying is this book is you're a big proponent of training and education, but this book is about educating from multiple different perspectives, right? So it's not just, hey, I care about infection prevention and you should too. You're having lots of different voices with different experience, but it's clear that you began to see even more of an emphasis on the need for training. And I think it might even be broader than maybe anybody realizes in these facilities. Like you said, you had a hard time getting people to even do proper hand washing. That's not a training that you just do for the direct care providers. That's a training that really applies to anybody who walks into that building, right?
Yes. And Justin, what I'll even say is when I worked with Doctors Without Borders team last year in Detroit and in Houston, and we spent a lot of time also boots on the ground. And we realized early on, especially in Detroit, so it's been a year to date, actually, when we were there, that we couldn't just go in and do like a normal assessment and then leave. Like it was like going into war and then saying, okay, we saw you once, we're out. Like we had to go back. And the majority of the time we spent one-on-one with our housekeepers and our CNAs because they were the most undertrained and they didn't understand infection control at all. I mean, I'll never forget working with one of the housekeepers and it was a COVID positive room. And I'm like, well, show me kind of what your practice is. And she walked right in there without PPE on, without doing hand hygiene. And I couldn't believe, like, she just didn't have the understanding of what she was stepping into. And to me, that is a huge disservice to this workforce. Like we've got to do better with this workforce and valuing the work they do. And then providing them with the training and education so that they can provide good care to our loved ones and the residents, but also protect themselves. Like she was in her mid-60s and she was not protecting herself at all.
And what is primarily the blame for that? Who is responsible for her to have known about hand hygiene? How could this situation occur where she is walking in and didn't know this? Is she not properly trained? Are the standards in the bar for training so low that this is common practice? Or was this a very unique practice do you think that you observed?
I would say it was unique that she walked into the COVID positive room without PPE on. I would say that was more unique. But what is not unique is the inappropriate use of PPE, the inappropriate, even like last week I was in a building and one of the CNAs walked into a room with C. diff and then, no PPE. So this is not uncommon. And what I would say is we've gotten into this. In long-term care, it's so heavily regulated, and we have to do these in-service trainings on anything new or upon hire, and it's almost a checking the box. And I think we're not doing a good enough job of providing one-on-one training. It's more we type up this in-service, read it, sign it. Now you've trained. Now I can move on. And I don't think we spend enough time with the staff to properly demonstrate the processes and then have them demonstrate back to us to show that they fully understand how to implement, how to put on PPE, how to safely take it off. We haven't taken the time to do that.
So really assessing competency.
Correct.
Like we say that they receive the information, but the way that the educational process is today, there's nothing that validates that they understood the information and could put it into practice. Is that safe to say?
I do. And what I will also say in fairness to these facilities that it's been even harder during this pandemic because they've had everything that you could possibly imagine as far as suggestions and recommendations and guidance thrown at them, and they haven't known what to implement. And then they've had short staff because staff either quit or because they're sick. So the education and training piece has greatly suffered in general, just because everybody's been we've been in emergency mode. And when you're in emergency mode, that's not the time for education, right? You're in a crisis.
Buffy, so you're hitting a really important nail on the head, and it's something that I'm glad that we're able to talk about. And I appreciate your passion, and I've seen the people, these residents and patients, and they need people like us to defend them and to support them. But the facilities and the administration also needs us to support them. How do we dance on that line where we're supportive and advocates both of the administrators and of the patients? So how do we assure that we can resolve this tension so that the needs of the administrators and of the patients are both addressed when they sometimes can be in competition, if you will, but they both need our help? How do we help both of them?
Well, I appreciate the question, and there's so many different pieces to all of this that I'll say two things. First of all, and especially during this pandemic, we have seen where our regulatory or licensing agency, they're not collaborative anyway, but they have pretty much taken this position of we're gonna find what's wrong, and it's become this gotcha whole atmosphere and environment where they come in and they're just nitpicky. If they see one little thing wrong, they cite the facility, and so there's this constant state of fear that is just abounding within this environment, and you're afraid, especially with all the guidance, you're afraid to do the right thing or not do the right thing, or it's been a very challenging situation to know exactly even what to implement, what not to implement for infection control. I've talked to so many administrators, and I think administrators right now are really caught in a bad place because in many facilities, they are not autonomous. They don't really have decision making. We've got these big corporations buying up these nursing homes. And so the people that are actually making financial decisions and decisions for the staffing are not the ones in the building. And I talked to many administrators who are just like, they're pulled in so many, they're kind of stuck. They're answering to the licensing regulatory agency. They're answering to their corporate board holders. They're answering to the patient and their families, and they don't have a whole lot of autonomy.
And sometimes they're answering, if they're privately owned, sometimes they may be answering to shareholders, in fairness too, yes?
Well, that's what I mean. And so the conversation that keeps coming up that I didn't anticipate at all when I'm talking to researchers and industry leaders is that we have to start understanding where our federal dollars, our Medicare and Medicaid dollars are going, and have that we need more accountability around the funding and where the funding is going, if it's actually being applied to direct care or if it's going into the shareholders' pockets. And so we can't just think about throwing money at this problem and it's going to solve everything. We need more accountability, and we need to understand where these dollars are going and to then make decisions based on that. So that's a big thing I'm hearing that we really need change in.
Buffy, we've really addressed and talked about a lot of topics here where we probably could talk for another hour or two. But I know that you have a passion, as do I, for the accuracy and integrity of the data. And in this case, let's talk about the counting of infections and of deaths in long-term care facilities. The CDC has said that about close to 400,000 deaths occur annually in nursing homes due to quote-unquote serious infections. Is that number underreporting the true number of deaths? How did the CDC arrive at this number? Did they use a methodology similar to what the CDC is using for how it counts COVID deaths by looking at death certificates or medical records involved? So how does the CDC know this? And is this number grossly underreporting the true incidence of death from serious infections, which would include, of course, superbugs, such as Clostridium difficile?
Thanks, Larry, for the question. I'm very passionate about data and believe that we absolutely have to use data to drive our decisions. And I will say that the estimates of 380,000 residents dying every year in nursing homes from serious infections came from research. It came from data that was not directly reported from nursing homes because that's the best that we had. And so this is really what started my passion, is that we don't have good benchmarking. We don't have all nursing homes reporting into the CDC's National Healthcare and Safety Network, NHSN, their healthcare associated infections. Until COVID hit, now every single nursing home is required to report their COVID information into NHSN. And this data, not only the COVID that their residents got, the positive cases of COVID from residents, staff, and deaths, and now they're starting to report vaccinations. This is my dream. I have been begging that this happen for years, and we need to expand this to HAIs, healthcare associated infections, MRSA, C. diff, CRE, like skin and soft tissue infections, pneumonia. We need to continue with this momentum and have these facilities to report these infections, because this is the accuracy of the COVID counts is the most accurate data we've ever gotten as far as infections from this healthcare setting.
Which would make it unfair to compare previously collected data to the COVID data, correct? Because they're not apples to apples.
Absolutely not. Nothing. Absolutely. It is self-reported by the nursing homes. Now, with that said, it is self-reported. So that does not mean it's without flaws. There's always going to be flaws with self-reported data. However, the estimates have come from data that was from research and from hospitals, and it was not specifically, there was some research that was from the nursing homes that was then extrapolated out and these estimates created, but it wasn't this 16,000 nursing homes reporting their infections into NHSN.
And I'll conclude by saying that I think there's also an important point to be made for validating those data, and I think that validation of the data is part of the integrity and the accuracy of the data, and we can't come up with the necessary corrective actions if we don't have a true gauge of what the numbers really are. So I think validation of the COVID data, validation of superbug deaths and infections are all very important.
Well, 100%. I mean, and this is where, we can model where we've been going for over a decade with the hospitals and them reporting their healthcare associated infection data into NHSN and the data validation. And, there's already a system set up. Let's use it. We don't have to reinvent the wheel. We have this national surveillance system that we can use. It's not perfect. There's a lot of problems with it, no doubt, but it's there and we can start to use it, and we are. And this has been a really huge accomplishment, I would say, that we actually have now. Every nursing home in the country is reporting at least some surveillance for infection. So this is one of those, positive things that have come out of this.
So this is becoming less art and more of a science, which is really where we need to go.
100%. 100%.
So we talked about the opportunities to educate just in this environment, but the last 18 months, I think, was a learning curve, even for just the governors of every state around infection control, infection prevention. I'll say infection control because it was reactive. And you made a really good distinction there during this conversation. But as we wrap, you talked about your book, and you said the book was really covering so many different perspectives and including so many different voices, and really meant for the general public and to increase this awareness. So what were some things, and you told me a good story story, so I'm hoping you'll tell it today. But what were some things that you noticed in the general public that just identified, just how much even regular people walking the street who don't even work in a healthcare setting, how much they just did not know about infection prevention?
Well, typically when we think about, especially this virus, it's been super scary. We didn't know. I mean, in the beginning, it seemed like a death sentence to everybody. And so, when we started emerging out of our isolation, I'd come out, and probably the biggest thing that I saw that to this day, if I see this, and I still see this to this day, is people wearing gloves out in the community. And I understand it from their perspective because they're wearing gloves to protect themselves. But if you really step back and think about this, if somebody's wearing gloves, they're not doing any type of hand hygiene. They're literally touching surface to surface to surface. If you see somebody in the grocery store wearing gloves, they're literally touching everything. They're not doing hand hygiene in between. They could still be touching their face and their mouth. And so I never understood why people were wearing gloves. It was still just as much you could touch your nose or your mouth and contaminate yourself as if you didn't have the gloves. COVID didn't come through our hands, as far as like through our skin. But I think that it's just like we're scared, and so we're going to wear gloves. Quickly, I'll tell you, when the restaurant started opening up, I went to a restaurant with my husband, and for the first time, and it was still kind of early on, and the wait staff was wearing gloves to every single person at every single table, and then go to the cash register and then come back. And I was like, I got to get out of here. I can't do this. So, it was just like, because I want to see people washing their hands or using alcohol-based hand rub. That's what we need to be doing right now. And that's good infection control right there.
It's the false sense of security that actually could lead to an increased spread
Quite a paradox,
of infection
Justin.
in that scenario because absolutely. Well, Buffy, phenomenal interview. Very nicely done. I've had so many conversations with you. I knew you'd be a rock star on this one. I'm certain we're going to have you back. Is there anything you want to leave the audience with before we wrap up?
No, I haven't met one person who hasn't obviously been impacted by this virus, by this pandemic, but also it's very rare that I meet anybody that hasn't had a loved one that's been impacted by some type of healthcare associated infection or a loved one in a nursing home. And so it really is a call for all of us. If you have a loved one in a nursing home, speak up, be part of their care plan, be an advocate for them. They need you. And even if you're in the hospital or going to the doctor's office, you can stand up for yourself and making sure those infection control practices, you can ask questions. I know it's hard. To ask those questions, but we all really can do it and really help to implement better and safer infection control practices.
All right. Well, definitely let us know when the book goes out. We will help promote it and point everybody in that direction because we're very much behind your plight to increase the awareness from everybody around infection prevention. And so I'm glad that you are adding that. You just got done getting your doctorate, then you go right into writing a book. So you love extracurricular effort. Yeah. So very nice job on the episode. Thanks for coming on.
Thank you, Buffy. A real pleasure. Nice meeting you and talking with you.
Likewise.
That was Dr. Buffy Lloyd-Krejci, CEO at IPC Well, and really, I can only imagine how difficult her job has been over the last 18 months. And interestingly, leading up to that, she was working on her doctorate. So her plate's been pretty full. And I know she's appeared on other podcasts and she does such a great job consulting. And we actually continued the conversation, Larry, after the interview. And we were talking with Buffy a little bit more in detail about what she meant by reactive versus being proactive in these settings and really in the community and in healthcare in general around infection prevention practices versus that control distinction, as we mentioned towards the end. And really what she said is a lot of times when she gets involved as a consultant, the facility has not previously had anybody that's been focused on infection prevention or let alone infection control. And if they do, they're fairly new to the industry or the role. And so, their experience may be limited. And that oftentimes when she gets brought in, it's more of a corrective action plan based on the results of a survey. And that right there is the detail that you need to know about being reactive. Why not prevent an adverse response on a survey to begin with by moving from control to prevention?
Right. Yeah, that was really insightful that she told us she'd like to think that she would be more often voluntarily called in as other people like her in this field so that they can help prevent these adverse events rather than correcting after them. And I think also that Buffy brought up a really excellent point that I'm sensitive to, and it's that the care and the advocacy that the residents receive in the long-term care facilities, this really is a reflection of us. It's a reflection of who we are. There's nothing more real and human about what's going on in a long-term care facility. And I think the way we observe ourselves treating those patients and residents and visiting them and particularly advocating for them, I think it's a reflection on us. And I'd like to think that after COVID-19, we can all look at ourselves and say, we need to be greater advocates for these people and really look out more for their safety than maybe we have in the past.
Yeah, Larry, you really said that succinctly. And honestly, anybody who listens to this podcast, even if they just stumble upon it, as Buffy said, has most definitely or very likely had experience with a loved one who has been in one of these settings and may have been in a long-term care facility during the pandemic. And so I love the fact that she doesn't want to give up just because some strides have been made, but to just continue to champion this cause. So as I mentioned, I'm sure she'll be back on a future episode. That's going to do it for this week's show, though. As a reminder, you can help support Transmission Control by subscribing on Apple, Amazon, or Google Podcasts, Stitcher, iHeartRadio, Spotify, or on your favorite podcast application. You can also access bonus content for certain episodes by downloading our smartphone application for iPhone and Android. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.